All right, dear doctors, thank you so much. This is Dr. Shahriar going to start the session, and today's session is on GIT. Now, is a small thing about these things, and if anyone is from the country where your time zone is different, we are not following your time zone. Okay, if you're anyone from Fiji Island and this that, we are not following your time zone. You have to follow our, and in that case, you can sleep early. I mean, in the middle of the day to catch up actually. If live is not comfortable, there's recorded version of the courses. In that case, you can join. Most welcome for that actually. All right, let's go and start the session. And we have an inquiry zone. GIT is opened up now. If you have an inquiry, please feel free to ask these questions there because we need to start. Here is the thing how to prepare GIT. There's an overview uploaded. There was a theory that is done. We're going through this recall course today, and there will be a mock posted and mock related. You can also uh, do some research on those questions, can be trending some of them. There's some of the handbook questions, example respiratory one we have mentioned, and also the GIT ones we have mentioned. But after today's class, at the end, I will also again show you the handbook particular question. And lastly, of course, SMA notes actually. I'm not adding the question banks yet because you guys are too new for the question banks. But a week progresses, I'll introduce you to the question banks. No need to buy question banks in advance because we'll be posting those things. Is everything loud and clear, everyone? Can we start the session now in that case? I'm in even more hurry than you guys. So as like some people are pushing because I have a flight to catch. All right, great. All right. But initial some of the demonstration are important because we have a lot of type of doctors who join the classes. A lot of people are like uh, left medical education and they didn't come to these classes. So for them, sometimes in the beginning we go a little slow because they sometimes get doctor in the beginning. Can you go a little slow? It's easy for us to catch up. Okay, so understanding everything, we have to uh, make this speed. I can go much faster. Like in that case, like half of you will not understand. If I start talking in my tone, you know, it will be faster for a lot of people, but we have to be universal, right? This is important. In the beginning, some informations we give slowly because so that everyone take and note down things actually. I've been an experienced teacher for a long time. I win some awards for teaching. I'm also programmer of the train the trainers as well. So you can trust me on teaching things as well. Great. Coming with that one, there's a GIT recall that is coming up. And here we go with the first question. Actually, ready, guys? Let's bring some positive energy. We don't want negative people around. So bring some positive as a yes in the beginning. Let's come with some yes in the beginning. Yes. The more bigger the yes, higher the chance of passing. All right, here we go. We started. Elderly, 57 years old man with, as you can see, with some mucus and blood in the stool. So, what do you think? What it could be? Diarrhea and mild abdominal pain, approximate investigation, small one because recall was like that. So, is it colonoscopy? Is it FOBT? Already 57. I like to mention the person is elderly, means more than 50, carries some risk already, and mucus and blood. All right. So, most appropriate. So, ruling out what? Ruling out colonoscopy because uh, it's a possibility. It's a possibility. Can be a cancer, can be a hemorrhoids, can be a diverticular, can be many things. So a colonoscopy will help ruling out everything. Is it clear to everyone? Is this thing clear to everyone? All right. So colonoscopy, even according to RSCGP or even like Australian Family Physician Volume 37, this one is the answer. I think it was not a difficult question. It is an answerable question. Okay, a man with intermittent colic abdominal pain, diarrhea, nausea, vomiting, and about 5 days following pancreatoduodenectomy. Now, this is tricky. What do you think? Intermittent colicky abdominal pain. So there was a pancreatoduodenectomy. Surgery was done. So in that case, what can happen? So we mentioned gastroparesis. What is gastroparesis, guys? Okay. Before going to gastroparesis, I'd like to mention, before going to gastroparesis, I'd like to mention why it is not an intestinal obstruction. Why it is not an intestinal obstruction? Because if you have been intestinal obstruction, there was two key terms I have mentioned earlier. One is an abdominal pain, and one is an abdominal distension. Am I right? So the abdominal distension, which is a very unique for most of the obstruction cases, is not present here. So colicky, pain, and also like if there is distension, then think about the obstruction, which is not there, so out of the option, because obstruction is popular in the exam. So after surgery like this, a quick question: is this a small surgery or is that a very big major surgery? Pancreatoduodectomy, is that a it's a very big surgery, very big surgery. Not only big surgery, very big surgery. Like anything nearby the pancreas is a very big surgery. All right. So can happen following surgery. These are the particular things actually, like start ulcer, gastrectomy, pancreatomy. So all this after these conditions, this gastroparesis thing. So gastroparesis is nothing but like stomach paralysis is kind of we mentioned actually. Now, how to rule out gastroparesis? This was also been a question in past actually. So gold standard way of like ruling out gastroparesis is gastric scintigraphy. Gastric scintigraphy. This was also a separate question in past. Okay. So following these surgeries, gastroparesis can happen. All right. Diabetes is another thing it can be. And also the way to diagnosis the gastric scintigraphy. Another key thing, if you can just check these parts, lower left, is commonly 4 days following the surgery. So you can see following 4 days following. So this is more common actually. This is more common. All right, good. Is it clear to everyone? So this is a little different one. So this kind of question sometimes they can also give you, which is like more from the surgical background. Don't worry, there will be more surgical things when you will start the surgery. Next question. So few information knowing about intestinal obstruction. Did we mention a little bit about the intestinal obstruction last day, guys? Maybe we don't, I guess. Did I mention a little bit about the obstruction? I think no, I guess. Let me give you a little idea. Even though it's our one of the hot surgical topic like intestinal obstruction, but you must be knowing there is two major. One is the small bowel obstruction, one is the large bowel obstruction. Now, X-ray wise, how we can make diagnosis? You must be knowing in small bowel obstruction, it's more like centrally. So small bowel obstruction, they are more like centrally located, whereas large bowel obstruction, they're more in the peripheral side actually. All right. Even in the CT scan, like the hostrations are more bigger in large bowel obstruction. Now, for AMC, which is very important to remember, a specific history. Does anyone know what is the very specific history for small bowel obstruction? And this is like a adhesion. So often you will be given a history of something like this, appendicectomy. Okay, like something like this. So a history of appendicectomy like a 10 years back. So this kind of history you will often get to see in a small bowel. So a small bowel comes more in the exam, and as a history of any surgery, as a addition can be things. Also, it can be also tested as a complications of surgery, complication of hernias. So like a hernia can lead to strangulation. Am I right? So those strangulation is intestinal actually. So that's another possibility. Whereas the large bowel obstruction, if there is underlying colon cancer history, so that's a possibility in that case. So colon cancer, because of growth, the lumen would be narrowed, so there will be chances of obstruction. Now, I'd like to also add something. Is it possible as a complication of IBD? If it is yes, which particular IBD you are thinking? Now, we have two versions. One is a ulcerative and one is a Crohn's. Now, one that is the transmural, like all four layers are involved, and that there is a narrow lumen. So this is the Crohn's disease. So Crohn's disease again can come as a complication in even in this particular cases of large bowel obstructions. Okay. Now, in terms of the diagnoses, okay, small bowel obstruction and the large bowel obstruction, like both cases is kind of similar. And I normally start with the X-ray. X-ray. Okay, so this is important. X-ray, then this the barium, whatever you say, and following the CT scans. So these are very, very important. And alongside, you might be needed electrolyte, lactic acid, because lactic acid, these things increase when there's any hollow organ that is got involved. So lactic acid can get involved actually. Surgical point of view, lactic acid is important. So X-ray, then CT, these are very, very important. Now, coming to the management section of a small bowel and the large bowel. By the way, guys, this small and large intestinal obstruction will be discussing in more details in surgery, but I'm giving you some clues right now. Now, if there is a small bowel obstruction, like from the top, like, NG decompression, and if it's not working, surgery. Eventually, it might be required surgery. Keep that term in mind. Actually, that is the reason it is very important to assess whether the patient need surgery or not. Small bowel obstruction, hemodynamically unstable. What is the next step in the management? This is the latest question. Sign of a like, small bowel obstruction, hemodynamically getting unstable. What's next? Are you going for like NGD compression and this, that, or are you going for surgeries? NGD compression or surgeries? In that case, we'll go for a surgery. We'll go for a surgery because the patient deteriorating. Okay, so they'll put you things like that. Normally, we appreciate as an initial as the NGT compression, but you need to understand which thing in which cases are more appropriate. If you're hemodynamically unstable, then definitely you have to open up the patient in that case. Okay. In case of large bowel obstruction, the same kind of thing, but this time rectal flatus tube and the a very important enema. So try with this enema thing and the rectal flatus tube not working, go for surgery. Is it clear for the large bowel obstruction, everyone? Clear for everyone? Large bowel obstruction, small bowel obstruction. These are the thing. X-ray initial, then following the CT scan. Okay, these are the more questions which we will be discussing in the surgery. But here's little idea. I mean, at least what to study for from everything related to obstruction. I'll be discussing more about these individual points when there will be our surgical classes. But these are the maximum recalls. I mean, all these points are related to one particular recall. All right, moving forward. There's a little bit about the things. Already this thing is been discussed actually, like small bowel, NGT compression, not working, surgery. Large bowel obstruction, you'll try rectal flatus tube, then you'll try enema, two things, it's not working, go for surgery. Anytime, any one of them, hemodynamically unstable, you go for surgery. Great. Next, we are discussing the GIT, and last day there was a lot of things related to esophagus. The amount of disease we studied esophagus, I mean, maybe not all of them you see in the recalls, but still they're important. Picture is given like this. Okay, now it can be anything. It can be anything. Esophageal dilatation and pylorotome. Any idea, any cases? First, tell me what is your diagnosis here. I would recommend you to see the lower part, this part. Don't just focus on this part, focus on this part. Also check in the stems, what they are asking. So they're probably asking dilatation and pylorotome. So sometimes your hints of the question are not only the question but also in the stems. So stems, if you see where you are expecting dilatation, where is expecting surgery. So this is a possible. Yeah, it looks more like a corkscrew, but if you focus on the lower part, it's more look like a rectal. This part. Okay, so here we go. This one is esophageal dilatation, and in this case, what will you think? Will it be achalasia or will it be a what do you think? It's more, I mean, not a classic achalasia. Classic echinacea looks more like a rat tail actually, even though, but when considering the options like dilatation, pylorotomy, I think I'm more towards the echinacea. It's a possibility. Okay. Uh, do you want me to show you some of the uh, relevant things about the some barium? Do you want me to show some of the barium testing? Can you go for that one? So that one time, we can finish. Okay, let's go for some of the barium. All right. Ready, guys? Okay. I'll be starting with something. You guys need to answer it. Okay, very quick. Let's see who is more quick. Let's see who is more quick. Any idea, any guesses what it could be? Some people are saying achalasia again. Is it? Some saying paleodystonicid. Is it? Interstitial, no, no, not really. Interstitial is like a telescoping. This one is nothing but hiatus hernia. This one is nothing, but this is a hiatus hernia. This is a little uncommon one, guys. This is hiatus hernia. Hiatus. All right. So few of the things you have to think macroscopical. Let me tell you one funny thing. Like, see, there was this histology thing in past. Now, how many of you were actual histologists, like by heart, or you just followed some of the techniques which I used, similar like this? Like, if this is a slide like that, and even though I'm using a coin, okay, this slide looks like this. Okay, this slide looks like this, and okay, this is a yeah, this is pancreas. Okay, this one looks like a bottle. Maybe it is a spleen. Now, how many of you use that technique? How many of you have used that technique? Like in the histology, like, okay, like because we have before the final exam, like 20-25 slide, also in pathology, by the way, like actually in the microscope or seeing the slide. All right, great. All right. So I think we all did. So same some of the thing you don't have to be a big expert. So if some of the things looks uncommon, so I think you can go for that one. So this one is a hiatus hernia. About the findings more and this that there is a website I'm telling you, its name is Radiopedia. If you want to know more about individual finding and want to go into more detailing about the radiology, then there is a website called Radiopedia. That's the thing. Otherwise, it's more like a picture testing. I would highly recommend it because there will be so many radiologists by the end. So Radiopedia is good, but if you want to see, so what technique I used to use when I was studying for the first time. So when I see this one, so it looks difficult to me to understand. Then what I did next is go to the Google and go to the Google image. Google and Google image is nearby, interrelated. So I check another five or six hiatus hernia. So I type hiatus hernia barium. This is a barium. Yeah. So I'll type the hiatus hernia radiology. So there'll be more slides like that. So I'll try to compare and contrast with the following one. Then you will understand the difference. So this is a better technique actually. All right. Okay. Next coming is like that. What do you think? What is your answer? No, this one, I mean, a bit easier than the others because it has a rat tail or a bird beak, whatever you say, in the barrier. So, what do you think? This one is more towards the achalacian. This one is a achalacian. What do you think about this one? Okay, some people are saying cancer as well. This one is again achalasia. It's more clear. Rat tail again. Yes. One interesting question is the MC question can be repeated in the same exam. So example, if you get an MI question, yeah, my dear, if you are up to started differentiating structure, you have to be a radiologist for that. Follow that technique. You will find so many radiology videos in the YouTube. Congratulations in advance. You can take in another uh, 2 3 months to become a radiologist for that. All right, I'm just joking actually. Like as I mentioned, the technique, you just see pictures, you just compare 5 to 7 pictures in the Google and just know the findings, say bird beak or the rat tail appearance. That should be enough for this MC thing. Otherwise, by the time you'll finish the MC, there will be another 200, 300 radiology. You have to be a radiologist if you follow that technique. Okay, anyways, this is achalasia. Now, how about this one? How about this one? Now, here we have a finding. This one, interesting. And it's a barium. Like, see, esophageal everything, it's related to barium because it's like a dye and something that is given to. And that's how when you take the retinosine, so that's how the films came up. So this is called some filling effect, filling defect or effect, whatever it's a filling defect. Now, this is going continuously. Suddenly, it looks like someone has eaten a bird. It's like that. Okay, DD it can be allergic condition. So it's between cancer and allergic. What do you think? So this is a case of the cancer again. This is a case of the cancer. Okay, so esophageal cancer. All right. This one is never tested in MC, but maybe for betterment you can remember pharyngeal web. So this is kind of like a web actually. Pharyngeal web. This is unusual. Like supposed to be continuous, but it's like a so suddenly it's like a web actually. So pharyngeal web. All right. Scleroderma is not much needed, honestly. Never seen coming actually in the exam. Scleroderma. So to wide mouth circulation, basically, hence they're calling it scleroderma. To wide mouth, yeah, circulation is more like a sac. So the scleroderma. If one, then you'll think more about cancer. Again, kind of like a filling defect. Like if it's one, and again it's a carcinoma. All right. We do have something about hypersomnia for you. Like it's no more prominent. It looks more prominent. Okay, this one is popular in the exam. So let me tell you, achalasia is more popular. Achalasia is more popular, and this one is very popular. These two are the things I have seen in the exam, honestly. The rest of them is just for your learning purpose. This one I have seen coming in exam multiple times. Rat tail is mainly for achalasia. Rat tail is mainly for achalasia, my dear. This one is a classic corkscrew appearance, but no bird beak. Now, how to differentiate with this achalasia and the corkscrew? This is the main point for the AMC, I'm telling you, because you will get either of them mostly in your exam. Okay, so this one, even the corkscrew, because we have another radiology which also looks like a corkscrew, but it was achalasia. Why? Because at the end there was a bird beak appearance. Do we have any bird beak or rat tail appearance in this one? Please check. This is the most important thing I'm telling right now. Is there any way it looks like a bird beak at the at any end? Not really. So it's a only clear corkscrew appearance, like a screw like this. The can openers, there was corkscrew type of things. So this is a classic esophageal spasm. This one is a Classic esophageal spasm. Is this clear to everyone? Is this thing clear to everyone? So far, so good. Okay. Now you remember the name, and later you just Google them. Okay. You remember all those names, and later you just Google them actually. Last but not the least, I want to ask if there is esophageal spasm, what is the initial treatment? If there is an esophageal spasm, what is the initial treatment? Answer: initial treatment would be giving drugs. Okay, initial treatment would be giving drugs like calcium channel blockers. Calcium channel blockers. This is like one of the specific medical treatment. Now, what is the conservative treatment? There is also conservative treatment that is included. Answer: you know, so initially, modification is important. Extreme cold and or extreme hot. Avoid extreme cold or extreme hot. That's another important because that's how it aggravated actually. Okay, so coming back to this one. Okay, we just gone through some of the barium. We just gone through some of the barium. Did you get an idea what barium to study? I'm not telling you that you become expert on that one, but did you get idea what bariums are tested? Now your job would be, please write it down. Check in the Google another 5 to 7 pictures of the same particular names. Another some of them with the same particle. So I'm just flashing you back. This is esophageal spasm because of corpse toothing. Then okay, hiatus hernia again. Okay, it looks more bigger than than any other. Then the carcinoma, it has a filling defect, some sort of defect in the middle. Like it feels like someone has came and eaten in one of the part. Scleroderma, two sacs actually. One sac think as a cancer, two sac you can think as a scleroderma because scleroderma is a systematic disease. It has multi-system of involvement. And pharyngeal web is like a someone is making a pocket in one of the cells, like a web. Okay, great. This one is looks like what? This one is again looks like someone has eaten one of the part. Especially in this side, someone has looked like eaten one of the part. So again, this one is a cancer. It's like a very classic one. I mean, you're supposed to get this one actually. So this is a bird beak appearance, again, reptile appearance. This is achalasia. This is again a achalasia. You'll just check the this part because the bigger version is given. That's why it looks confused. But you're supposed to get things like this. Yeah, this part. Okay, so again achalasia. And this is last but not least. So because whole stomach thing you can see is because of the barium. And so this part is nothing significant. It's again right. It's a by the way, I'm not going detail into hiatus hernia because hiatus hernia I will teach you in the surgical field again. So that time I will tell you a little bit more about the hiatus hernia. Okay, so for now, just remember that hiatus hernia barium can be given. Okay, it's more common in ZERD and the obese people. So some part of the stomach actually came into in the upper side actually. That is how the finding can be detected actually. All right. Um, is that recapitulation and the revision was clear now? Everyone, is it clear now? Yes, it is. Yes. Sorry for taking some time. If there's a spasm, you can go through the nitroglycerin. This is the okay. Next coming is important thing. 49 year of the history of alcohol in the emergency department. He's known history of esophageal gastric varices. Now this one is going towards varices. Last year we asked a question, the reason of some of the bleeding, like, or you can say upper GIT bleeding, or bleeding from the stomach, bleeding from the esophagus, whatever it is. Varices. Esophagus from the bleeding, varices. Okay. Has been on beta blocker to prevent the bleeding. You can guess now what it is coming next. There's a physical examination finding given, and his vital does not looks good. He has hepatosplenic ascites, this that. Started on proton pump inhibitor. He continues to vomit bright red blood. Is taken urgently and EGD to showing bleeding from the esophageal vein. Okay, so it's esophageal bleeding, loud and clear. Treated with sclerotherapy, which is also done for the varices. Now, varices is the tip of the iceberg. Main disease is inside. Now, what is that main disease? What is that main disease? Something portal hypertension. Portal hypertension because of liver. Portal hypertension because of liver. So our main, so tip of the iceberg is that bleeding. The main problem is in the liver, cirrhosis of the liver. That is correct. And which leads to high portal hypertension. Portal hypertension leads to this esophageal bleeding. Clear now? So what we can give is octreotide, like beta blockers, like sclerotherapy, banding, ligations, TIPS procedure. A lot of things are involved in this case. He's admitted to the ICU because his vital is deteriorating. You can see this. What is the definitive management? They ask very specific. Now, what is your definitive management in this case? So definitive management here, because already is given beta blocker and it's probably not working in a proper way. So you need a band lig. You need to do band ligation to stop it first, actually. Okay, so that's the thing. See, shunt, it's a controversial, like whether you need the shunt or not. That still is a controversial. Like example, if the person associated with hepatic encephalopathy by any chance, because the person is deteriorating, would you recommend any tips procedure or any shunt procedure, tips or shunt, same thing? I repeat my question. If the patient is having hepatosplenomegaly by any chance, would you recommend any tips procedure or any shunt procedure at this point? Okay, so answer is a no, because shunt can um, aggravate. Yes, there is an exception, which is a spleno-renal shunt. Only one exception. Okay, spleno-renal shunt. Right. The propranolol or any beta blocker or octreotide, these are the initial management. In the beginning, we can do that. All right. So here is the thing, as you all can see, the levels, as you can see. So starting banding, ligation, dose, drug, octreotides, all these things you are trying. So banding, ligation. Further, you need the sclerotherapy, later balloon therapies actually. All right. All good. This one will help. Maybe you can take a picture of this one. Okay, I'm giving you 10 seconds more to absorb it. Yeah. So wait, take your notes. A lot of people may not be at first literacy. Need to respect them as well. All right. Clear now? All good. Moving. Which of the following? See, I mentioned you to earlier, if you remember, one of the pattern of the question is like which one has the greatest impact or like a risk factor. Did I mention that one? So risk factor related, one question can be called. Following has the greatest impact development of esophageal cancer. Your call now. Final answer. 10 more seconds. I'll give you more than 10 seconds. Final answer is a varices. Two-edged sword, pre-malignant condition. Two-edged sword, pre-malignant condition. This is so varices esophagus is quite a leading. Varices esophagus is a pre-malignant condition. Can you give me example of some of the other pre-malignant conditions, guys? All right. There can be many actually. Yeah, the cervical cancer related anything like high grade cervical cancer, high grade finding. When you do the pap smear or HPV DNA, this is very, very important. Very important. Yeah, human papilloma virus. So anything which is related to cervix, yes, pre-malignant. Well done, guys. Good job. Next. This time, let's see how much you have gone through this radiology thing. Now, radiology given, and what do you think? Complaining about dysphagia. Now, when they're saying dysphagia, that maybe not the good news. So, what are you gonna do now? Drug, dilator, surgery. They're asking definitive management. Last I mentioned when they ask about the best definitive, and they're offering surgeries. Okay, so in the most cases, your answer would be surgery. In that case, answer would be surgery. Again, another question in past it was tested. They ask about achalasia. Ask about achalasia. In achalasia cases, again, what is the best or most definitive or most appropriate answer would be surgery. What type of surgery it is? Myotomy. Myotomy. All right. So here is the thing. So dilatation. Then there's option for Botox and it's a surgery. And here is the thing. Bird beak appearance. This is the classic one. Or you can say rat tail. All right. Moving forward. A 40-year man with anemia. Okay. How we know anemia, like hemoglobin, MCH, all these things are good. Upper GIT endoscopy done, this part, which is normal. This is a very important finding. Always check in the question. Do you have anything related to upper GIT endoscopy? Any idea? Any cases? This one, um, like a young to middle age, or like kind of young. So in that case, what do you think? You're asking the best investigation. So best for celiac. It is a biopsy, if you remember. Let's discuss a little bit. Celiac is related to a condition which is related to GIT, but there will be a lot of extra GIT features, if you remember. So eventually, there are situations like your villi in the intestine get affected, which is responsible for absorption. So there is less absorption leading to malabsorption. So a lot of vitamin, minerals, a lot of things will get affected because of this. Okay. It is also kind of like it's autoimmune at the same time, which is targeting the villi. Okay. So they are mainly targeting the villi. So they will have problem to the specific type of food. What are those? Which is like brown, barley, rye, oat, wheat, barley, rye, oat, wheat. So they will have problems. So if you eat these foods more, they will affect the intestinal lining more actually, and there will be more flattening of flattened villi, flattened villi. So flattened villi, less absorption. So what we can do is a gluten free. You go to the any super shop nowadays, it's gluten free diet, gluten free diet. Okay. Last but not the least, another option can be GAPSO. Great. So for the celiac disease to remember, the most accurate is a small bowel biopsy. But last I mentioned what is the initial, some of the initial anti-gliadin antibody. This can be some of the interesting as per the John Mutter, then anti-endomysial. Endomysial can be as a next. And biopsy is the last one. Right? That's good, everyone. As per the John Mutter, we have to remember a few things. So anti-gliadin antibody initial, anti-endomycin antibody is the next, and biopsy is the best. Most cases in AMC, they will ask you about the biopsies and things like that. Wonderful. Next, GIT problem, upper GIT endoscopy done. This happens many times that the person is going through something. You did an endoscopy, but either you cannot pass through into the intestine, and sometimes you are not sure, even after doing the endoscopy, what it is. In that case, what to very loud and clear. In that case, we'll go for a capsule endoscopy. It's just a small capsule, which is like a tablet is given, and it goes through the intestine and this that all the parts, and it's eventually comes into the toilet. You have to return it back, by the way, guys. It's expensive. You cannot take it, but you cannot flush it. Okay, so that's a capsule endoscopy. So for the capsule endoscopy, some cases it is not recommended. If you have a by any chance stricture or obstruction problem, in that case you cannot give it. Otherwise, that particular thing will be also obstruction can happen. Now, it is very important to rule out bleeding. Some cases, Crohn's disease finding like a very small ulcer where the regular endoscopy thing you cannot send or can be very painful, whatever. So these are the cases actually. Very rare cases there can be capsule retention, but you can take the procedures in that case. Are you loud and clear about the capsule endoscopy? This is five-star, guys. I don't know, very easy question, but it is tested very often. Yes, you have to return that capsule or you will be fined. Okay, next. Scenario of a man who got epigastric pain after eating food with a friend in the restaurant. Past history of anaphylactic shock after eating a carrot cake. Now, about a carrot cake, there are some shops like a 7-Eleven in Australia. As have you seen in a lot of um, petrol station, there is like seven. Like, you will be familiar. Those of you who will go to Australia, as soon as you will go to Australia, you will be familiar with seven. Those of you living there already know what I'm talking about. 7-Eleven shops. Now, in 7-Eleven shops, if you see, there are some foods available. Actually, one of the popular thing is a carrot cake. Carrot cake is, by the way, quite popular in this country. Now, eating carrot cake, is it because of carrots? Okay. Or is it because of something else? No. Most chances it's because of the eggs. Is it possible that egg allergies are common, guys? Is it possible like egg allergy can happen? Of course. Egg allergy is a possibility. Now, this brings us to one of the popular pediatric question, actually, even though we're not going through the pediatrics, but one, my job is to compare contrast things. Popular pediatric question um, about vaccination. Now, I'd recommend you guys to study sometimes, if possible, Australian immunization handbook. You can just search with this term, you'll find that PDF, Australian immunization handbook. Now, as per that one, uh, there are vaccination like MMR. Now, can we force vaccination to a kid or to a parents actually that your kid has to take this vaccine? Can we force? No, because in COVID we have seen a lot of people, a lot of kids even didn't take the COVID vaccine because they don't believe into that one and they have a belief that if we take vaccine, something bad will happen with us actually. Okay, so summary, even though no matter what is your government is, so vaccine is something you cannot force on someone. So same goes with the MMR. A lot of people have a belief that MMR vaccine causes a lot allergy. So there's a very popular thing. So it was believed that uh, giving MMR vaccine will lead to allergy or egg allergies. So egg allergy and the MMR vaccine has some interrelation, which is like a myth. So it's not true actually. So there is no relation as a counseling, and even if you go to the some MC part 2, you will see this myth or see this counseling that this um, vaccine has nothing to do with egg allergy. Please write it down. MMR vaccine repeating it again. MMR vaccine has nothing to do with egg allergy. Clear, everyone? MMR has nothing to do with egg allergy. It's a popular pediatric record. Okay, and extra side like today, I introduced you to two important website. One is a Radiopedia. Sometimes radiology more HD view you can see that, but otherwise you can check the Google Images, which is more easy and faster. And immunization, anything, Australian immunization handbook. Sometimes try open it. So egg is correct. It's because of the egg you can have that allergy. Or if the nut is present, the nut can be also responsible. Is it possible? Nut is nut allergy common? Is nut allergies are common? Very good. So if you see egg allergy, peanut because it has nuts, milk, beef. Yeah, milk rather than allergy, I think more causes lactose intolerance is another thing. Okay, I would recommend all the dear doctors who are already in Australia, try to drink lactose-free milk. Okay, because we Asians, like 70% Asians, to some extent, partial or like a full or whatever, they have lactose intolerance a little bit. Even I do myself, like, but it's little bit. Like, for example, if I drink one glass of milk, nothing will happen with me. But if I drink two glass of milk, then there is some problem. So it's like a very little or partial actually. All right, it's kind of like that. Let me know in the comment section if you also have this problem. So the very easy solution is if you drink anything related to lactose free, or if you make anything like a even like eat days or something like that, you can use the lactose because it's very easy to get in Australia. I mean, there's like a lot of bottles and packets available, lactose free milks actually. All right, here's another extra thing I would like to add about urticaria. Can you say this is as a hypersensitivity reactions? Yes. So these situations can be mild, moderate, and severe. I like to highlight the severe one. How would I understand it is severe? Now, if it is possible, a bee sting has come and bite someone, actually. We're talking about bees, not honeys, actually. So, anyways, bee sting. So, bee sting got bitten and it can be very dangerous, actually, some cases. A quick question, first time bitten by a bees is more dangerous, or the second time bitten can be even more dangerous? Answer: the second time, the re-exposure. Remember, mast cell re-exposure. Re-exposure can be more dangerous. Anyways, coming back to this one, urticaria cases, severe is a matter of concern. How we understand it is severe? It will also has respiratory distress. So that means your lungs would be also affected in that case. So it will present it as a not only the rashes and all these things, but also presented with wheeze at the same time. Presented with wheeze. So in that case, under severe. Now, what is the management if severe urticaria? Okay, in that case, adrenaline, adrenaline, or you can say IM adrenaline. Moderate cases treated with steroid. Mild cases treated with simple antihistamine. So this is one, this is two moderate, and this is three. So this is again a 5-star topic for the MC exam. Is it clear? Please mention in comment section. You can write as a memo. Looks good. Just a caution, guys. Many of you, I mean, say when our winter is coming, we check our cupboards or any drawers and bring out some of the old things like this because we don't want to throw them away. Trust me, this is a very big reason of you get your allergic rhinitis, your um, sneezing, all these things to start actually. Yes, the dust mite or all the dust. Okay. Already a time like a spring season is dangerous. Another is like when the winter is coming, this thing can be very dangerous actually. And of course, if it's the related to dust, like dust allergies can be also very common. Allergies can be very troublesome for some people. Those people have severe allergies. They understand it's very much troublesome. So about allergies, it's better to prevent than cure, and you should use a mask as much as possible. Even dangerous than the some cases cigarette smoking actually. I mean, if you wear the mask, you will get very less allergies often. Yes. 65-year-old with epigastric pain and burning. By the way, in generally, smoking has other things like cancer and this, that. In that way, smoking is more dangerous. But if talk about allergies, this technique I tell, this is more important. 65-year with epigastric pain, burning, and H. pylori negative. H. pylori, is it positive? No, it's negative. But still, you give him omeprazole. All right. What to do next? Are we going for this one? No, we're not going for this actually. I mean, it's not positive. The same question, if H. pylori positive, then what to do? You will do next. Then we'll go for A as a follow-up, isn't it? Last two we learned that one. So this is out of the option. This is out of the option because it's negative. So since it's negative because of epigastric pain and this that, we'll do it again if ruling out if there is any underlying pathology like cancer or anything else. Okay. So it's endoscopy thing after 6 weeks. So it's an endoscopy thing after the 6 weeks. So to exclude the pathology, repeat the endoscopy in 6 weeks. Reference RSAGP. Moving forward. Even in the John Mortar, they also do mention about the endoscopies. Showing you the question again. And also, let's check the age group. Isn't he also a risk factor? Like a 65 epigastric pain can be a risk factor for something big like cancer or even ulcer, all these things. Next, which of the following is the first test? So it means like a first or initial test performed in a patient with a lower GIT bleeding. Now, before going into that one, tell me the causes of lower GIT bleeding. Even though it's a surgical topic for us, but still we can discuss it. What are some of the causes of lower GIT bleeding? Now, for lower GIT bleeding, starting with the number one. Number one is diverticulosis. Second common is not hemorrhoids, angiodysplasia. Then come this hemorrhoid. These are the three. Then the other things like anal fissure or anorectal carcinomas or colon cancers, and so on, so on, so on, many things actually. Sigmoid, um, all these things. Now coming to this one, first is rule out for lower GD bleeding, and that's a pre-colonoscopy. Lower GD bleeding things, these things can be ruling out by colonoscopy or sigmoidoscopy, whatever you say. So ruling out lower GIT bleeding is very, very important. Most common is diverticulosis. Second most common, angiodysplasia. Third common cause is hemorrhoids. So here is a thing which I like to highlight. Yes. Good question. Do we do colonoscopy when there is a bleeding? Very nice question. I'll clarify the doubt actually. What do you think, guys, about that one? It's a nice question. Uh, this question also came to my mind at some point when I was also learning the AMC. When I was also like first time, do you really do? The answer is a if it's about like a uh, very mild bleeding, like say the bleeding which you don't, uh, which you are not very sure, like the bleeding which probably you're not very sure, like a, so is it important to find out the source of the bleeding? The answer is a definitely yes. So you definitely need colonoscopy segment. Now, if it's so much bleeding is happening, some cases. Now, that cases, you probably cannot perform actually. If there is so much bleeding, which is called like a acute flood, or so much bleeding ongoing, then you can't really see. Even if you send that one, yeah, in that case, probably you can't see probably because so much things are coming, so much bloods are coming. So in that case, you can, I mean, so much means so much, it's like a flood. Okay. So if it's a little leaking, understand the point. So if it's like a leaking bleeding, yes. So much bleed means hematochezia. Probably. All right. As I said, when you to rule out, any bleeding, rule out any small bleeds. Like example, there is hematemesis melena, or you see something red coming up in general. In that case, actually. So why in that kind of bleeding? This is not the first line because you need to stabilize the patient first. Actually, you need to stabilize the patient, then you can consider doing those colonoscopies or sigmoidoscopies or whatever the way, or you can give some drugs also to stop the bleeding. There's a lot of things like that. Is it clear, everyone? Even in generally, a lot of even tests, even like CT scan. Can we do a CT scan when the patient is hemodynamically unstable, for example? Can we do even a CT scan when a patient, like, it's kind of like that. So if because of bleeding, your patient is unstable, probably you cannot perform that much. So you need to safeguard the patient first. Then you see whether you can stop the bleeding by other means. I mean, by giving a lot of drugs are also available to stop the bleeding. Then you try to do the procedure. Like bluntly, if you're going, you will not able to find the spots. Is it clear now? I hope it is. So stabilize, stop bleeding by some drugs, and then proceed with again colonoscopy and all these things. All right. Here is the thing: lower GIT bleeding causes. Ruling out is very important. We rule out by doing, you know, colonoscopy. Colonoscopy is sigmoidoscopy. So diverticulosis, angiodysplasia, cancers, inflammatory things like, ulcerative colitis and Crohn's disease. Okay. Another one I like to highlight. So different places as you can see. So hemorrhoids are here, ulcerative colitis, the colon, polyps, cancers, dysplasia, diverticulosis. Anyways, this is more related to our surgery. Did you remember, guys? I mentioned anorectal bleeding is a part of our surgery. Yes. So don't worry, it will come again with us. Here's few lines for us. Most common cause of lower GIT bleeding in infants, anal fissure. This one I took from a pediatric book named Nelson. It's called also lower GIT bleeding in infant, anal fissure. It's called lower GIT bleeding in children, polyp. This is very interesting. Most common uh, cause of lower GIT bleeding in adults. Tell me now. These two are clear for adults. Number one is one diverticulosis. Diverticulosis. Right. Moving forward, right, guys? This is a little tricky question. This question is sometimes confusing. 38-year woman comes to your office several months of progressively worsening dysphagia. Progressively worsening dysphagia. So this is our question to dysphagia and be limited to some are limited to esophagus. Okay. Difficulty swallowing feels like food stuck in the chest. Try to adapt physical position because to push the food in. Although difficulty was the first with the meat, with water first actually. Okay. She lost 7 kgs and very anxious. At times she was having chest pain agitations and this that. She used some anti-ulcers, but no benefit. So a situation was anti-ulcer not working. Now she's also used to smoke and now stop. Which of the most likely diagnosis? Very interesting question. So there is a keyword is a weight loss given. Keyword is a weight loss given. And we do have dysphagia, and there is also hoarseness is given. Now, why we don't think this can be a like a larynx, like some other type of cancers actually? Because the dysphagia more indicating esophageal cancer. Am I right? Dysphagia more indicating esophageal cancer. There is a point because of that you can think it can be achalasia because of dysphagia to liquid. There was some part actually. Yes. But if you see the other points, in cases of the other one, uh, like you mean to say achalasia, you don't have a gross weight loss, right? So that's one of the things. So she lost 7 kgs, right? So this is one of the things. All right. So we'll think more this thing as a cancer because of the weight loss thing. So they'll think more as a so barium might be initial. Later we might go with a CT if needed in that case. The single word progressive is more important to rule out esophageal cancer. So it met the criteria of progressive dysphagia, but it does not follow that thing related to dysphagia, unfortunately. Like normally, if it's esophageal cancer, we appreciate more if, you know, dysphagia to solid. Forget about the smoking thing. All the condition somewhere can be related to smoking. So forget or ignore that is, smoking part. Okay. So it may not be very prominent thing for you. Right. So normally, if it would have been the very classic question, so dysphagia from solid to liquid is more appreciated. Okay, clear everyone? If you also remember, there was a popular question: upper two-third of the um, esophagus related to squamous, lower one-third is related to adeno. Also, Barrett's esophagus is related to adeno. As a mnemonic, we remember one-third AB. Do you remember this thing, guys? One-third AB. That was the mnemonic actually. And adenocarcinoma is most common in whole Australia at the center. These are few of the questions related to esophageal cancer. Again, John Mukta, esophageal cancer. So here is the thing. And commonest in the whole world, it's squamous. But in Australia, particularly more common is the adenocarcinoma. This situation can be presented with dysphagia, hoarseness, and also the weight loss. So weight loss can be striking feature. So if you come back to our question, do we have weight loss? Yes. So we do have the weight loss. So and this is our main striking feature, which is you will not get in achalasia in this way. Okay. So these individual terms can be very, very important and also can be associations like varices. But here is the line which is not matching with our question. We usually appreciate dysphagia to solid. Now, if you ask, is it possible to have weight loss in achalasia? Yes, that's possible. But if you ask, is that a usual symptom? No, not as a usual symptom like cancer. Clear, my dear? No 45-year female with ulcerative colitis, um, like a bloody diarrhea. We understand ulcerative colitis, which is a IBD. We learned last year details. Now, ill, not a good sign. Ill means maybe unstable. Abdominal distension and mild bowel sound. X-ray showing large bowel in the periphery, not visible. Okay, looks bad. What is the management? Now, is it initial management or is it a definitive management you need here? Please see, your patient is becoming ill over the time. So, is it a stable patient or I would say unstable and dilated bowel at the center? So, your patient become ill with abdominal distension, another bad sign. So, is this patient looking stable or is patient looking a bit unstable? Even though they didn't mention about the BP, but still, condition deteriorating means also unstable. Condition deteriorating means also unstable. And when the blood pressure is below 90/60, then hemodynamically unstable. One is getting progressively getting bad. So in this case, is NG tube will work? Probably not. We need a bowel decompression surgeries. And the abdominal distension is a main keyword here. This can be anything bad it can be. So bowel decompression and dilated large bowel. So if we mention dilated large bowel, is this NG tube is also related to large bowel? Not really. NG is more towards the small bowel artery. So this is out of the option in that case. Great. So as a initial, if it's initial, if they ask this thing as a what is initial, then it's a different. But here I think from the point of view, because it's deteriorating, even next or appropriate, whatever it is, it's bowel decompression. Now see, sometimes initial depends on the situation. Okay, sometimes initials also depends on the situation. It's a large bowel. It's a large bowel obstruction. Yeah, diagnosis, large bowel obstruction. That's the thing. See these IBD cases like even ulcerative colitis or Crohn's, mostly Crohn's can leading to bowel obstruction is common. And nothing to not understand because you didn't highlight the first slide. See, let me clarify again. Inflammatory bowel disease, inflammatory bowel disease, inflammation, and there is a possibility that lumens are involved, or if it's a whole four layer involved, like it's a Crohn's disease. Now, did I mention last time Crohn's disease can lead to narrow lumen? Yes, and Crohn's disease can lead to obstruction, fistulas, and many other complications. Now, clear? And how it is correlated? Because ulcerative colitis is a correlation or inflammatory bowel disease correlated with obstructions. Clear now? Yes. Right. And here is line again. Crohn's disease. Again, there is a correlations. Yes. So this complication things can happen because of the narrow lumen. Narrow lumen can lead to obstruction in future. Here is the line obstruction and the diarrhea. Now clear? Oh, good. Great. Did you remember last step? See, IBD managements are also very important. So initial treatment or mainstay of the treatment is a sulfasalazine. Did you remember this particular thing? If it's an acute case, in that case, because it's autoimmune, so in that case, corticosteroid. If the initial treatments are failed, there's another question asked. If initial are failed, in that case, what? In that case, you need to remember as a azothioprine. So management of IBD is extremely important. Next question. 35-year-old truck driver presented complaining about abdominal bloating, abdominal pain, and diarrhea for 3 months. Colonoscopy done 1 year back. It was normal. So it's a long history of colonoscopy. Now, what do you want to check? Please check the history, the occupation. The occupation is very important. So this is nothing but any cases before. Okay, I can understand you are choosing D as well. I think you guys are correct. Now, because it's a truck driver, it's a possibility the person can develop diarrhea because of anything. It's because of traveler's diarrhea, because of like a um, any chronic disease like STDs, anything can lead to diarrhea and also maybe giardia. You never know because they're going into remote areas. All good? Okay. Old woman with a low calcium and other blood reports are normal. What is her cause of having low calcium? Very common question. In generally, women are having low vitamin calcium and low vitamin D. I always recommend taking some sort of outside vitamin D if that is possible. Now, most cases it is very common because of the dietary deficit. Is it more common that the female they do dieting more? And is it also true that they do mostly inappropriate diet? Why I'm saying inappropriate? Because they prefer eating less, eating very less. When you prefer eating very less, that is inappropriate diet, actually. Proper dieting means, you'll just cut down the calories, but you will eat the necessary ingredients, actually. Okay, so please check carefully. I mean, you are totally cutting a lot of things, and you can have a lot of issues then. Yeah. Still not like a eating disorder, I would say, technically. But maybe bulimia nervosa, because bulimia nervosa, they do have that sense always. Because, like, see, uh, I have to look like attractive, I have to look. So they have that sense. They have that sense. At least bulimia nervosa. Anorexia nervosa, they don't have any sense. Right? Right. So old women with a low calcium, yeah. So they can have osteoporosis, this, that, dental issues, even cardiovascular risk. Anyways, next one. Yeah, even postmenopausal women. Highly recommended to take calcium and vitamin D, especially if there is osteopenia. Now, let's go for this one. Patient having investigation for ZERD comes with the upper GIT bleeding, H. pylori positive. Now, need to control the bleed. H is also still bleeding. What is the next initial step in the management? Last day, did you remember I mentioned you were taking bleeding peptic ulcer disease? Was there a title like this last day? Yes, there was a title like this. So your answer was injection adrenaline. Did you realize now why the questions were more AMC specific? I mean, why the theory were more, specific, which I was teaching because of these particular questions. So this is the thing. Bleeding peptic ulcer, if you can remember, injection adrenaline. Matching now with our theories feels good, right? Right. But don't forget that you also need to give PPI, not only adrenaline, but also the PPI. But more important is adrenaline to stop the bleeding first. Next, this time 55-year coming to your clinic complaining of recurrent abdominal pain, which is radiating towards the back. Please highlight radiating towards the back. Will last for few hours, no specific triggers, not related to eating, not seems to related to eating. ECG obtained, which is normal. So it's not heart related, not related to heart. Abdominal ultrasound is inconclusive. Lab showing amylase lipase, or everything is still normal. Following is the likely diagnosis. Now, interesting thing, if your if it's showing radiating towards the back, what does it indicate? A middle-aged man is having these things, and an abdominal pain which is recurrent and radiating towards the back. So it can be pancreatic. Gallstone one can be radiating towards the back, but more, I would say, tip of the shoulder more. And radiating towards the back, we use more the for the pancreas actually. Now, is it possible that in pancreatic cases, amylase lipase in the first few hours you can find it normal? Is that a possibility? I have seen even few cases like that. So in this case, so it's a pancreatic. Abdominal pain related to any question, any important of them. There can be abdominal pain. But the key word here is this one, radiating towards the back. This is important. So here the line is mentioned. So Amalia's life is can be normal, the early stage. Thank you. Some common pancreatic diseases, acute chronic hereditary cancers. All right. In future, I'll tell you more about them in surgery class 3. A child increasing vomiting. See, this time, I mean, not adult, a child with increasing vomiting since last 3 days with night symptom. We often call it nocturnal, like bloating, nocturnal, all these things are present. Since 1 week, he's cheerful and happy on examination, not dehydrated, but his diagnosis. Final answer, it's ZERD. Now, this is another point to be noted. Even after the vomiting incidents, the ZERD babies, after vomiting, vomit cheerful. Question, in PS, little lethargic after, because projectile vomiting and there's lot vomiting, everything eventually comes out, they become more lethargic. Is it clear to everyone? Yes. So ZERD versus PS is important for us. So ZERD, here are the terms. Yeah, they can give you milk flows freely from the mouth. They can sometimes give you, there's a special line, milk flows freely from the mouth. Very small kid, if it's a little older kids, bloating, heartburn, night symptoms, because they eat at night and symptoms are common. Yeah, right. Please note, ZRD can be associated with hiatus hernia. Take note, hiatus hernia. Check some radiologists today. Right. All right. All right, guys. So can we go for a break now? Can we go for a break now and come back and continue after that? Okay. So let's go for a 10-minute break at this point. If anyone joined late, I hope so you have gone through GIT overview, and there was a theory class. If necessary, revise it again. Then we're going through the recall class, mocks, handbook, assignment notes. So for now, these are suggestion. In future, two things I will add more for you. One, that is question bank solving, and another one is a Shahriar's MC guideline group question solving. Actually, okay. So because we have closing the group now, so I think after today's class we'll post something to, it will help you finding a study partner. Actually, I'm posting it now, so those of you who are interested finding a study partner, you can mention your location. Actually, I mean, I'm posting it in my Facebook group. um, so in your relevant group, please mention your location, because so that, because someone who living in Fiji and someone is living in Bangladesh, so it may not match because there is like a 18 hours almost difference. Okay, so Australia, New Zealand, Fiji Island, they should study together, or cross country, doesn't matter. Those of you living in the Sydney areas, I would recommend you can go to some of the libraries like Westmead libraries together. A lot of my students in past, they have gone through that. And if someone living in Middle East countries, you can study with anyone from India, Pakistan, Bangladesh. Doctors living in India, Pakistan, Bangladesh, Nepal, Sri Lanka can study in between themselves. I'd recommend more to study in between yourself, because so that the English fluency even gets better with time. Actually, some of you might be good from the beginning, so we're not concerned about that. But if day to day, if you're not using English, in that case, this is a chance before MC exam to improve your like a vocabulary and speak in more fast manner. Actually, all right. So I hope that helps. If you have inquiry, do we have inquiries on GIT opened up? And now we are opening the study partner zone. So please look into our group. We'll be back in 10 minutes. So you guys put your, those of you already, if you have a study partner, no need to mention anything. But if you're looking for a study partner, please go and check that Facebook group. Mention your um, location and mention when you are planning for exam, that can be also some people interested, like either November or you are targeting February, March. Please mention that one too. Right. Is it loud and clear? Please, before going to the break, please mention in comment section. Is it loud and clear? Okay. All right, everyone, posted just now. So refresh your group and check it. Find your study partner. If necessary, you can also tag anyone or inbox anyone or comment there. Will be good. It's a good chance, guys. This is a great chance. In the beginning, most study partners are paired. Later, it will become difficult. So please go check and find it out. Thank you. All right, everyone. Are you guys ready? Please comment in the comment section. As we said, these are some of like pillars, like purview, theory, recall, mock. Just a quick thing. Many of you didn't take that respiratory one. Please make sure you at least submit your paper. Let me tell you one thing. Those of you, attend all the exam regularly. Sometimes if may not possible in one day, you take another day preparation, but you submitted it. In generally, in long term, if I tell you the study or the graphs of like or the craft of lot of the doctor's progress. So those attended everything. All exams, and at the same time they managed to get like almost 7, 8 in most of them, um, or 70 or 80% in most of the exams. They almost pass the exam almost always 100% otherwise. Okay, so this is very important. So do not skip anything. Even if it is late, but please take it actually and be honest. Like, what's the mark actually? If it's little less than 7, if you get, in that case, give a quick revision actually, because once you finish a system, then you can give a revision in one day. Okay. So, and if it's already all right, if you get 7 or 8, then you don't need to revise at this moment actually. Is it clear, everyone? So, below 7, give a quick revision for one more day, thinking that your something has been missing. If you get 7 or 8 or 9, so probably you don't need a revision at this point actually. Right? Okay. Now, why not passing is 5 out of 10 or 50% as like in the main exam? Because in main exam, a lot of questions together, you usually appear actually. Okay, so you have to think. When you are going for only respiratory, you revise only respiratory. So if it's 50% passing in small exams, it will give you a false positive result for you actually. Okay, so think your passing is 7. Is it clear, everyone? From any mocks, your passing is 7 or 70%. Okay, if it is a individual exam, when the time will come and I will take the bigger exams like computerized, that time it will be 50% for you, the passing mark. But if you're taking the smaller ones, it's as more as like a learning. These exams are more as like a learning. We upload the document and this that. Make sure you take it at least actually. Okay, the break is finished. Now it's time to get back to. So this was our last question number 19. We picked up ZRD and we discussed some differentiation versus pyloric distances. Trust me, in when you go in MC part 2 someday, this is also a very popular question, ZRD versus PS. And you have to ask the kids according to that. Now, going back, there was a salmonella outbreak. What to do? This is more like I would say, a population health type of question. Okay, so I'd like to just introduce you. So Salmonella outbreak, Salmonella by Salmonella typhi, and this, that. Now, I'm not sure I mentioned in this class, like there is a test for this, like the PASU, like a blood culture, agglutination test, or known as Riddle test. Then there's the stool, and then the urine. This is like a week-wise 1, 2, 3, 4 salmonella testing week-wise. Now, and outbreak, if there is an outbreak, then in that case, it's stool culture mainly. So, outbreak cases, it is culture. Otherwise, it's a week-wise. Is it clear to everyone? Yes. Great. So, outbreak cases, it is, reference from the RSCGP. This was a difficult question, actually. I mean, I was very confused, actually, about this question while solving. Okay, young man came from a trip, so you can say trip related question to respect, but some GIT symptoms like mucus, blood, and this, that. But it was a previous history. Now also there is weight loss and this, that. This question, I feel a little bit incompleteness. Okay, but anyways, what is your diagnosis? Young man. Okay, young man say 25 years. Okay. Uh, Nothing mentioned about, aborigine. There's another missing thing, trip to which particular country? Yeah, 2 years is a bit distracting, that is true. Okay. Let's make a summary. The person is present with mucus and blood in the stool at this point. And previous history of trips. Let me assume in that way. Previous history of multiple trips. Okay. I mean, I've seen cases like this. Previous history of like multiple trips. Okay. Now his chief complaint is blood plus mucus. What do you think? What is it? Something has entered. I mean, we think because of back to back trade, something probably has entered. All right. At the same time, some weight loss we can see is also present. Now let's go and see, even though incomplete question, if we have anything for that. Now, can it be ZRD? No, not really. ZRD will be more for aborigines, fat in the stool. Even though it's an incomplete question, I mean, it can be ZRD if they mention about malabsorption, foul smelly, fat in the stool. So this is, we're going through the exclusion method. This is out, first of all. Now, thinking about colon cancer, can it be colon cancer? Because weight loss present. Now, this is another important thing to be considered. So mucus and blood, and there is something weight loss. There's a possibility. It's a possibility. Okay. Now, another thing, um, amoebic liver abscess or amoebic colitis, there's supposed to be short history, like short history, not like a long. So the long history, I think it goes more with a probably ulcerative colitis. And technically, ulcerative colitis can lead to cancer. This is the only way I can add little puzzle to this one. All right. What do you think, guys? I think it's not our problem. It's the question is bit incomplete sometimes. What do you think, guys? Yes. A small tip. I mean, there's a website called MedBullets. Yeah, long history, can be, can be. Age is supporting IBD. I mean, if we consider the age can support IBD, ulcerative colitis, and mucus and blood. Okay, I mean, I took the chief complaint part actually. The going to the trips and this that can be distracting. What do you think, guys? As we mentioned last day, there is one two question. There can be distractors. Okay, what is something has to do with the 2 years back? Okay, unless like HIV, yeah, yeah. So recurrent episodes of mucus and blood. So it's a possibility of IBD. I mean, you can skip that travel part probably. Agreed, guys? We can skip that travel part. But think about them individually because they can be tested. Alright. 18-year male came with a bloody diarrhea and you made sigmoidoscopy. 10 centimeter um, friable mucosa. Now, if you can remember, guys, and this is a something 5-star. All right. So where did you find this one? If you remember, it was related to ulcerative colitis from while we were studying John Mukta, theory 1. I added this special line for you if you remember ulcerative colitis. So friable mucosa, special line. So your initial will be, mainstay will be sulfasalazine. So this is that particular line. I mean, extra line which I have added from John Mukta, and another blood mucus thing, area of friable mucosa was characteristics. All good, everyone? Next, Somalian man. Now, sometimes you'll also find this type of travel or kind of like region related question with the low anal fistulas. Somalian. Now, you need to understand Somalia is from which part of the world? Somalia. Yeah. So to detect something, Somalia is from which part of the world? Yes. So if you're thinking African, it's correct actually. Now, in from that particular reason, which one do you think is more common? The schistosomiasis and the perianal abscess actually. So I think we'll go with more with the schistosomiasis. Another past question, Somalian baby related question, vitamin D deficiency. But in general, a lot of parasitic infection are common in some of the African regions. So one of them is a schistosomiasis. Now, can you tell me more about the schistosomiasis, guys? Can you tell a little bit more about the schistosomiasis, everyone? So as you can see, like a parasitic infection, definitely, and through the contaminated water. So this is the like possibility of having schistosomiasis. Is it possible to have hematuria? Is it possible to have hematuria in schistosomiasis, like a bloody urine? Yes, that's a possibility. Some cases, because of um, coming into the abdomen and this, that it can also lead to abdominal pain and blood in the stool at the same time. So these are some of the possibilities. Have you ever read anywhere if you have a history of schistosomiasis or long in your body, in future it can also lead to some liver problem and cancer in future. So liver problem and some of the cancers in future. Let's say liver fibrosis, liver problem, and cancer in future. Yeah. So this type of question, by the way, guys, Somalian man, I mean, of course, Somalian man who is now living in Australia, they meant to say that. Somalian man who is now living in Australia. Okay, so he might have this thing inside his body because when he was coming, he was only get tested with tuberculosis, not schistosomiasis. Okay, so this regional history as a GP for Australia or as a doctor for Australia are very important because when you go to Australia and you start practicing someday, see, I mean, if you study well, it's not that much long. You actually can go there in 1.5 years. Patient with esophageal varices, um, so that means bleeding, which is repaired twice. Now he's again coming with the bleeding. Which approach is better for him? To least chance of hepatosplenomegaly, I think we have discussed this thing already. So if there is a chances of hepatosplenomegaly, normally shunts are dangerous, dangerous, except for one, and which is a splenorenal shunt. Now, splenorenal shunt also has another name. What do you think? So this mentioned lessen the chance, like least chance. Tips has higher chance, guys. It has even high chance of hepatic encephalopathy. So everyone, so splenorenal shunt, splenorenal shunt, yes, also known as a Warren shunt, because any one of them can be given in the exam. So splenorenal shunt, also known as the Warren shunt. I took it from a textbook, which one I forgot. For hepatic encephalopathy, least chance. Here's the explanation. I'm holding here for a few seconds. So here is the line: low incidences of hepatic encephalopathy with this particular shunt. Yeah, more clear view now. Reference. Possible. No, no, not usually first aid. Usually first aid does not have things like that. What is Warren shunt? They don't ask. They give a title topic and then give some explanation. Not the same. But some USMLE first aid books, Kaplan books, med bullets, these all are USMLE relevant. They are quite organized, including master report actually. All right. But make sure one thing, in order to jump for just good things, your syllabus may not be so big. Okay. Great. All right. Next question. A 40-year patient traveled to Indonesia. Now, again, travel related. The central abdominal pain transferred to right lower quadrant. Then a few days later, subsized spondyl now has difficulty abdominal pain, fever, chill, no signs of peritoneal irritation, otherwise examination except for painful diarrhea. Keyword painful diarrhea, keyword traveling, uh, and abdominal pain. A lot of key points. Does appendicitis has painful diarrhea? Never heard things like that. Is it? Does appendicitis has painful diarrhea? Some people mention. Is it like that? Never heard. Except for yeah, but that's different. Yeah, the pelvic one. Yeah, it's not common. Now we have few other options: diverticulitis, Crohn's, inflammatory bowel disease. Now I think 4 and 5 technically both looks same. So IBD also sometimes can have travel history. So Crohn's disease, I think we picked up. I think 4 and 5, anyone you picked up, it's correct. Skipping the, I mean, appendicitis, why? It's mentioned. Is there any nausea, vomiting? No. Is there anything like something? What is the surest sign for appendicitis? No, not shifting pain. There's a one thing which is like the surest sign for appendicitis, which is missing here. Because they're giving otherwise examination normal. That means what? Right? Means number one is a rebound tenderness. Rebound tenderness. So since they're given otherwise examination normals, means rebound tenderness is also negative, which is one of the like specific sign. And many MC exam, if it's for appendicitis, always remember, other than the abdominal pain, nausea, vomiting, fever, they will be also mentioning about the rebound tenderness. Yeah, fever as well, just now mentioned. Yeah, fever is a possibility as well, because appendicitis, itis, so those are the things. So it's not appendicitis. It's not cancer because I don't see any weight loss. Diverticulosis, it is not. Do we have any bleeding, lower GIT bleeding, guys? Yeah, it is true. I mean, say chronic diseases like Crohn's disease can be mimicking a lot of conditions. Yes. You can have mild. I mean, fever is an important point of differentiation of many diseases. So, if inflammatory bowel disease, say inflammatory itis is there, but there fever can be very low grade. Whereas in appendicitis cases, the fever can be high grade. Clear? Okay. So again, ulcerative colitis, Crohn's disease. This is already given in our note section. You can have a look at that. The area of fragile mucosa in one of the particular we have seen. We can see IBD related a lot of questions. We can see today IBD related a lot of questions today. Right, guys? You can take a screenshot. You can, or I'm giving you 1 minute. You can note down some of these points actually. These particular terms can be useful for you. It can be useful for you in terms of some of the travel related questions. Taking you a second. Okay, 10 more seconds. In previous one answer, not diverticulosis, previously mentioned, lower GAT bleeding will be your chief complaint in that case. Chief complaint matters also, guys. Chief complaint also matters. Diverticulitis cases, the chief complaint will be coming with the bleeding. Okay. Do you want me to brief this one a little bit if you have time? Okay, let me allow people to first of all take notes. Okay. I'll try my best. And this one is difficult. Okay. Now, very, very popular. One of the thing question. These are like the question I have seen coming in AMC a lot. Now, traveling to Thailand. One that is very clear. Traveling to Thailand, people are familiar with this one, like the STDs. Right? Someone is going to the Thailand after coming back. There is genital discharge, like gonorrhea, syphilis, HIVs, many other things. That's the possibilities. We have also seen not only um, the STD, but after coming back, if there is a short intubation period, it is also possible to have pneumonia, like after just after coming from Thailand, respiratory distress, then it can be consolidation or pneumonia. Or if it is a loose motion, then it can be diarrhea. Okay, so these are possibilities. Or at the time of traveling, say someone is drinking fruit juice from the roadside and this, that, there's also possibility of traveler's diarrhea. Okay, so there's also possibility of traveler's diarrhea. Okay. Next thing, as you can see from Iraq. So from Iraq, anyone can guess which popular one has been tested in MC so far. So Iraq for TB, right? So going to like country like India or even Bangladesh and this, that there's a possibility enteric fever, dengue fever, these are quite common. Somalia earlier we have seen. See for Somalia, you know, it can be which one? Earlier we have seen schistosomiasis and vitamin D deficiency. Same as with Sudan, again, yeah, vitamin D deficiency. So these will be some of the small or bullet things for the exam. Then again, Indonesia and Jakarta. Indonesia, Jakarta, what do you think which can be important? Again, dengue is supposed to be more common. Dengue is supposed to be more common. Aboriginal areas. Aboriginal areas, what is that? Giardia. Giardia is more. Okay. Another one we have seen with a Legionella earlier, subconjunctival hemorrhage, leptospira, subconjunctival hemorrhage. That can be more related to swimming in stagnant water. By the way, swimming in stagnant water, subconjunctival hemorrhage was a relevant question. Going to western part of the Australia, going to western part of the Australia can leading to what? Australian encephalitis. And whereas in Aboriginal cases, we already get it's Giardia. Speaking about the traveler's diarrhea, now if you are going already areas like third world countries, better to say third world countries, in that case, traveler's diarrhea. Okay, I hope you're writing. Another one, um, going to the hilly area. Every country has some hilly areas. Now, which countries do you have more hilly areas? I think most of the countries. So if going to hilly areas give rise to malaria. Quick question. Um, is there vaccines for malaria? We know there are prophylaxis, but nowadays is there any vaccine for malaria? Alright. Now, one interesting thing about the malaria. how to differentiate with some of the remaining. Malaria will have a long incubation period. Okay, so normally in some of the others, there will be in a week after coming back the problems, whereas in malaria cases, almost like a 2 weeks after coming back, there will be the problem. Right? Clear, everyone? There is Cambodia, which can be liver related to cholangitis, liver abscesses. These issues can happen. Right? Yeah. Clear some of the area related things, guys. Oh, leptospirosis can be related to subconjunctival hemorrhage. Someone asked this thing. This all thing has been tested in past. This all thing has been tested in past. Mm. Great. Yeah. Vaccine for malaria. Yes. It has been introduced already. Vaccine for malaria. Now it is according to WHO. It's available. Officially, they started giving. So more for the malaria prone areas. A lot of African countries are getting the malaria vaccines a lot. Now, here is a question. After a conference will manifest floated force vomiting, then suddenly pain in the retrosternum, or say not ischemic disease before. After resuscitation, what is the most appropriate next step? Okay, moving forward, I think you have seen this question before when you mentioned the conference mill. There's a possibility of doing a lateral chest X-ray. Sometimes hints are not always here. Sometimes hints are also given here. When you see lateral chest X-ray, why suddenly popped up? It is because they want you to do this particular test, like for Boerhaps. Did you mention last day? If you have Boerhaps, situation like Boerhaps, you can have respiratory symptoms, like because of Boerhaps, because things are ruptured. So there'll be massive pressure. So part of the lung will be collapsed or squeezed. And this can give rise to some pneumothorax. So you urgently need an X-ray in that case. Can they eat? Not really. So IV fluid, antibiotic, nothing to do. Admission to ICU. Is it required surgical repair? This is an emergency and required a surgical repair. Definitely, it's a requirement. All right. We found this thing question last year. So middle-aged man, say 40, had a history of surgery on allergy few years back. Now complaining of hoarseness for a month, dysphagia for 2 weeks. Now, in this particular case, hoarseness uh, more than dysphagia. Previously, we have seen a question where dysphagia more than hoarseness. Now, this is very important to remember for the AMC exam. Great. Now, this one goes with a laryngeal person because hoarseness over dysphagia. Now, same one, if it is related to dysphagia more than hoarseness, then answer is this one. Here, dysphagia over hoarseness. I think we have seen a question in past like this, right? Right. So this is more like a medicine question, or you can say surgical question, or a more like a ENT question. So anywhere you can consider this question. Now these are in general sign symptom of laryngeal cancer. It can give rise to so many things, including ERP. In past, I have seen a question with laryngeal cancer. They were mentioning about the ERP. So a lot of doctors were confused. Okay, maybe it's only ear related problem. No. So as a referred pain in laryngeal cancer, there can be ear pain as well. Please remember that. Just not much days back, I think last year it was tested. Next one. Patient given amoxicillin metro looks like for gram negative coverage and post-colectomy for 5 days. Stool culture reported as Clostridium difficile positive. Next step in the management. Yes, please. Keep going. I'm taking a minute. Yes, I'm back. So, guys, our diagnosis is loud and clear. Clostridium difficile associated diarrhea. Last day, guys, I mentioned you to read about the um, antibiotics. I mean, antimicrobials. Did you read that part? Antimicrobials treatment. There was a section in the John Morta. Did you revise that part, guys? That section has so many other antibiotic names, guys. Any model that can come. You can see this one. So every year they bring one of them. Actually, this year there's another year enteric fever, another year the typhoid one. They keep bringing. Now, which one here is more important? We are going to the vancomycin here. Okay. Now, why it's not metro? Why it's not metro here? Because metro has already been tried. Okay, it's because of the amoxicillin and antibiotic like that that this situation can happen. Antibiotic associated diarrhea and metro is already given. So next option is a yeah, metro already given, my dear. So metro is not a choice. So it's between C and the D actually vancomycin. C and the D, the vancomycin. Yeah, one is the oral, one is the IV. So it's not necessary to go with IV at this point. Okay, you can understand there are some certain indications of IV. The patient is sometimes not in that situation, but if the diarrhea has been increased so severely, in that case, you can consider the IV. Otherwise, many times that oral treatments are fine. Is all cases of diarrhea we are always giving IV? Is it true? Or a mild cases we stay with oral? So I think mild to moderate cases we stay with oral. If you look severe diarrhea, we go with that. So it depends on the question. If you find that diarrhea severity is higher, you go with the IV. Otherwise, oral vancomycin. Is it clear now, my dear doctors? It looks to me a mild case, I think. It looks to me a mild case. And initial treatment is not work like which is metronidazole is already there, already started. So we like to go with the oral vancomycin. Okay. Another thing to remember, if you use vancomycin, it can give rise to red man syndrome in that case. Now, another thing, like if vancomycin is even not working, do you know what it is next? Check the chart and tell me. If improvement, of course, you will continue with vancomycin. If not vancomycin, there's a term, fidaxomycin. Remember the name? Fidaxomycin. Are you familiar with this name before? Maybe not, yeah. It's new kind of. So fidaxomicin, 1 days. I recommend you to check a little bit about in the Google pseudomembranous colitis management, and you can also check some management in the Google actually, right? As extra, or you can check med bullets as well, because less information are given in journal in terms of that. So some cases a little extra study will help. Sudden vomiting, dysphagia, epigastric pain, patient who had gone a previous gastric fundoplication. Okay, a gastric fundoplication procedure. So you see, most surgical things can be asked in MC a lot if you have noticed that. Right. Okay. So in that case, what do you think? What is right? Gastric fundoplication. This is interesting. This can be a little hard actually. Keyword: the surgery is already done, and also vomiting, dysphagia. These are ongoing. So is it a barium, X-ray, CT, ultrasound? So when you're going with A, I'm also going with A, barium solo, and now here is the thing. So late complication of this particular gastric fundum ligation, it depends on the complication actually. Now, if there is a gastric fundum ligation and it's related to vomiting and this that, then we prefer the barium more actually. In our question, what was the complaint? Our question was um, the same thing: dysphagia, vomiting. These were present. Okay, so this particular thing were present. So we'll go for the barium. Is it clear, everyone? With the reference, is it clear? Wonderful. This one may not be present. So this one I recommend you to take a picture actually. And this one is hard to get. This particular one. Many others I think is already covered in the notes something. So this one is little uncommon actually. I had difficulty to find this one's reference. I think this one is taken from one of the RSCGP or maybe rank course. I'm not sure. 25-year patient has the asthma since he was child in ZERD. So see again a ZERD case with a 20 million feels like trouble with a certain types of food on endoscopy, which is finding given eosinophilic esophagitis. So they already give you the finding. Some cases they might tell you constrictor, multiple constrictions or constricture they will be mentioning. The answer is what to do next. Next would be okay. Many went with D, but isn't it? It is been mentioned. It is a eosinophilic esophagitis. Now, if it is eosinophilic esophagitis and history of asthma, so we already mentioned ZRD and asthma has 30% of association. So, and another allergy condition, allergy condition are like brothers. So that means eosinophilic esophagitis. So you need to give a eosinophilic esophagitis treatment as well. All right. Now, do you have this difficulty of dysphagia because of uh, increasing ZRD? Why they have mentioned particular types of food is because of some particular type of allergies with some particular type of food. So that is reason this is eosinophilic esophagitis. You are giving inhalated fluticasone. Last time we discussed about it. So eosinophilic. So solo this thing. So fluticasone twice daily. You don't need dose for AMC by the way. Fluticasone. So first of all, withdraw the offending thing. If there is that particular food, yeah, you need to remove that. Double PPI, why it would be when you have eosinophilic esophagitis. B is a wrong answer. This is not a exact ZERD question. Understanding the question is also part of the exam. This one currently having a lab finding. Always focus one thing. Let me give you a tip here. Always focus on the lab finding. Lab finding means the surest finding. They like to they like to focus in that part, that this problem, and now physical examination showing this problem, lab is showing this problem. Okay, since lab is showing this particular problem, yes, definitely 100% is correct answer. All right, eosinophilic esophagitis. There will be so many questions with double uh, two diseases are mentioned. Okay, get ready for this roller coaster ride in AMC. So many times there's two diseases given. You will be thinking like which one's treatment to give. This is another pattern of question. So if you want to know about the pattern, there's two diseases given. One disease need to be prioritized. This is also commonly names. Amoxicillin followed by diarrhea. Second, costume deficient diarrhea. I think it's easy peasy one. Everyone can answer. Fast and furious answers required without any delay. This is costume deficiency. Reference given before. Simple one. 50-year male father died colon cancer at the age of 7. His maternal auntie also has colon cancer. How will you screen him? So first of all, I'd recommend you to open up colon cancer and go to the RSCGP, which is somewhere related to our surgery or screening. So colon cancer and RSCGP, and you'll you need to read that part. This is really important and 5 star for the exam, but not really our medicine topic. But still, it's okay. Getting familiar is fine actually. Now, would I like to go for colonoscopy now? And colonoscopy after 5 years. Now, if I did a D option, colonoscopy now and every 5 yearly. Which one do you think is the right answer? I think so definitely is this person is 50 year. So colonoscopy now and every 5 yearly. So look out for that option as well. Otherwise, you can go with the colonoscopy now is also not a problem. And it is also recommended. This chart looks smaller, but you will find just go to RSCGP. Just go to RSCGP and type colon cancer. You will find this chart. These two charts, you'll find it. Right? We're not going there. Right? There's another one. I mean, always do check this one when to perform the fecal occult blood test. Actually, you might find FOBT. FOBT, you can also type in Shahriar's MC guideline. You might find 3 4 questions related to that. Yeah, okay. Best answer, colonoscopy now and every 5 yearly. Okay, next. 48-year woman admitted to the emergency room with a productive cough and maternal fever, and she has often um, central chest pain and regurgitation of undigested food, but does not suffer from acid reflux. The symptom have been present for 3.5 months, which affect the food and the brain. Just exertion, airfield level being a normal size, what is the most likely diagnosis? Yes, please. This is emergency condition, first of all. Age. It is showing air fluid level in just behind the normal size heart. So it's going with what? What do you think? Pharyngeal? No. Why it's not B? Does not suffer from acid reflux. Did I mention hiatus hernia is related to CERD? Very common. It's almost invariably related. So does not suffer with inhalation. There's another one. can be an answer is an achalasia. We expect it's given dysphagia to liquid, and this that feature more. Emergency situation, is it common with achalasia? Good question. Achalasia is the close call near to this one. Achalasia is the closest call near to this one. It depends actually. It's quite a close between achalasia and the pharyngeal pouch. Yes. Okay. You can, I think, let's go for a inquiry zone discussion for that one. I think it will be a nice discussion in that case. That whether go for a pharyngeal. So you can take a screenshot of this one and just post in our inquiry zone of the GIT. I will answer that back actually. Okay. For now, it's pharyngeal pouch, but we have a very close call with achalasia. So we'll see that. Depends on questions sometimes. I think we're familiar with achalasia. I think we don't have any doubt about our knowledge, but sometimes the question, uh, some part can be incomplete and this that. So about achalasia is a tight sphincters, usually no heartburn. That's the key. Liquid followed by solid. Some cases they present with both liquid solid together. Okay, so this is the thing. And at the same time, it can be acquired by trypanosoma, which you can remember. About the investigation, barium is the initial, and uh, further you can do the manometry. Further, you can do manometries. We also know about the treatments related to achalasia because it's a tight sphincter. So either a drug, like a um, either a drug or a dilator, drug dilator, or a surgery. Zinkers can be a nice differential as well. Next one. Let's discuss this part in the inquiry zone. Okay, city given as like this. Okay, triggers of vomiting in daily weight loss and persistent epigastric discomfort. Probable diagnosis place. So kind of like alcohol problem and the persistent epigastric discomfort. 55 years. So what do you think? It's pancreatic carcinoma. Pancreatic cancers. Uh, I personally think if we make this question complete, uh, it is also supposed to be jaundice that is present. What do you think? If usually a pancreatic cancer is usually, you know, compress the biliary part, which is quite a common. Okay. So personally, I think that jaundice part can be missing in this question. Be aware in the main exam because sometimes recall we collect, it may look a little different some cases in the main exam because they'll give you the complete version. but the radiology one would be clear. So when we bring one radiology, make sure you see some more other radiologies from these particular sections. Right. Great. So I think we are at the end, guys, almost. I hope you enjoyed the session thoroughly. And these are some of the handbook questions. These are some of the handbook question. Um, Before you go, I'd like to demonstrate something for you guys. Just give me a second. Speaking about this, I mean, I just shared a link in the Zoom about our video channel library. This is how it looks like. I just shared a um, link here. Shared a link. So everyone, I hope you are looking into this one. This is our video channel library. Are you guys added to this one? I hope it is yes. You don't need to answer this. Okay. So I'm just demonstrating this one a little. If not, I'm sharing the link. No need to answer, guys. Just check. I'm sharing link in case of anyone. No need to answer, guys, as a yes. If it is a yes, no need to answer in the comment box because I'm sharing a link. Okay. So if you see, this is how it looks like. When we click at photos, I mean, this demonstration is laptop demonstration. Mobile may look different. I don't know how mobile one is looking like in your hand, but it's a laptop demonstration. Now, when you click media, photo, album, let's go to the album. Certain good albums are there. Now, about this, like 5 months, pros and cons about the classes. It's your job to go through this, like some important informations actually. Say attending live is key to success. Friday overview, Sundays. All right, so a few informations this that regarding a different time. In different time, I uploaded different things, so can be very very useful for some of you. This some of the basics. Again, media album. Why I opened this one? Because we have a radiology, and even till last month it's updated. So you see already there is 203 radiologies. As I mentioned that technique, as I mentioned that particular technique, when you open like this, when you open like this, and just keep scrolling by because findings will be given here. Okay. So by the time, I mean, you don't need now to finish this one, but at the time you're finishing medicine, then you can scroll actually then. See, there's obstructions, this, that, well, feces, all this thing has been tested since like last 6 7 years actually. All right. So just keep scrolling sometimes and keep practicing. Okay, so this will help you for radiology, I can guarantee you. Just keep scrolling, sometimes keep getting idea. If one of them you don't understand, just double check in the Google with that particular time. Say first one is a MS, multiple sclerosis, and there's white matter. So if you want to see more similar, just Google it. Now, in that case, you can just go to Google and you can say multiple sclerosis. Okay, type like this and just type images, Google images, sclerosis and radiology. You see, many more. Okay, so this is the practice I want you to do in coming days. But this is just a tip and the idea. If you can start, we have meritorious doctors all over. If you can start early, that's fine, but normally recommended by the end of the medicine to check the radiology file and the folder. So this is how it looks like. I'm sharing the link again of that radiology. You can just click now and quickly scroll through. It will be really helpful. Thank you so much, dear doctors. This is your mentor, Dr. Shahriar. As we mentioned, our next class is on when? When is our next live class? Our next live class, not this Sunday because we are celebrating Eid. So Eid Mubarak to all of you. And I'm also flying to Turkey. I'm not sure anyone from Turkey here. If anyone of your friend or this, like, you can meet me at Istanbul. I may hope to see. But our next class it will be on 10th actually. Okay, because of Eid break is already given in the routine from the beginning. All right, so don't get confused and come to the light class of Sunday because of Eid we knew it. So the date is given on the 10th actually. And just to show you, 10th means what? 10th means it's so 10th means our next class would be on Tuesday. Clear everyone? So Tuesday we'll see you actually. Oh, someone was in Turkey. No, no problem. If you have any friend, feel free actually. Yeah, same time. As always, time is the hopefully same actually. All right. As I said, because I'll be traveling, if there will be any issues and if I got stuck and out of internet by any chance, I'll try to let you know in that case. But there was a lot of history. I've been also traveling. I usually try not to miss classes. Actually, I'll manage some. Thank you so much, guys. See you. Good luck. Actually. We'll be posting this version in YouTube, and from next versions, we'll be posting in the Facebook groups. Actually, thank you so much. Thank you. Pray for my etc.